Welcome everyone to the supply chain disruption amidst COVID-19 webinar series. This is number 4. We are grateful you're here with us today. My name is Marcy Stoll. I work in the Executive Development Programs Department of the Broad College of Business. And my role today is to help you and to help the presenters. So if you have any technical questions or difficulties, you can reach out to me via chat or email. My email is showing there on the screen right now. During the webinar, we would love for you to submit your questions using the Q&A feature of Zoom. So you tap or click the Q&A button on your device, submit your question, and then Dave Frayer will introduce those questions that he has time for to the panelists. So please submit your questions as we go today. Thank you for being here, Dave. Welcome.
Great. Thank you so much, Marcy. And welcome to everyone. We're really pleased that you were able to join us here this afternoon for the fourth in our series of webinars focused on supply chain disruption amid COVID-19. It's been about 10 months since our last discussion with all of you, but we're very excited to be able to resume this series and share some additional insights. My name is Dave Frayer. I'm Assistant Dean for Outreach and Engagement in the Broad College of Business at Michigan State University. I'm going to serve as your moderator today, and I'm assisted by Nick Little from our Center for Railway Research and Education, as well as Marcy Stoll, who you just met from our Executive Development Programs team. This session is being recorded, and the recording will be made available on the Broad College YouTube channel sometime following the session today. Today, our discussion is really focused on the topic of vaccine distribution, and we are incredibly pleased to be joined by a distinguished group of folks who will share their insights and ideas as we move forward. Joining us today is Dr. Vedat Verter, who is the John McConnell Chaired Professor in the Department of Supply Chain Management, as well as the Department Chairperson. He will offer some brief opening remarks. We're also joined by Ms. Linda Vail, who is the Health Officer for Ingham County Department of Health here in mid-Michigan, as well as Ms. Marion Whicker, who is Deputy Chief for Supply, Production, and Distribution as part of the COVID-19 Vaccination and Therapeutics Response Team at the federal level. Again, we're very grateful that all three of you were able to join us today for this discussion. Our format is really going to involve our panelists responding to a few key questions concerning strategies and practices that are being deployed to help both develop and distribute the vaccine in light of the pandemic. We will address as many questions as we're able to following the initial remarks and discussion. And I would encourage you again to share your thoughts and comments using the Q&A function here within Zoom. To get us started today, I'd really like to invite Dr. Verter, if you could take a few moments and share with us just some opening remarks to kind of set the stage for what we're going to be covering today. Oh, Vedat, you're still muted. My apologies.
No,
there you
the
go.
Apologies are mine. Thank you, Dave. And welcome everybody to this edition of our series on supply chain disruption under the pandemic conditions. I wanted to mention that we have ongoing research in the department itself, particularly on healthcare operations and medical decision-making processes that is inspired and motivated by the pandemic itself. We're looking at capacity management problems, and we're groups of researchers looking at unpacking the health and economic impacts that we simultaneously suffer from in under the pandemic conditions. In addition to that, we also have another group of researchers specializing on supply chain resilience research that gained significant relevance under the current conditions. Now, going up to the college level, I would like to mention the Masters in Healthcare Management program as a degree program we offer that is relevant to today's topic, as well as the executive development programs that is offered through Dave Frayer's side of the college. Now I'm going to turn into making a couple of comments on the topic of today. And just to set you up, and this is gathered from the Bloomberg tracker, this is the moving average, 7-day moving average of the number of vaccinations that are administered in the US. And as you could see that it is somewhat flat in the second half of December, and it gains some trend starting particularly the second half of January. The good news is that the 7-day average as of January 30th, which was 4 days ago, is 1.35 million daily shots. Now, if you look at this in more detail in the next table, so this is the same data with a bit more detail. What is interesting is that the very last column, that actually the states who administer more than 900,000 shots on the average are around, high 50%, 60% usage of the supply of vaccines that are delivered to them. So as what I see here is that as the number of vaccinations increase as we go through the learning curve and making the process better, fine-tuning the processes, I also see somewhat of an increase in the gap between the number of vaccines delivered to the states and the number of vaccines actually ended up in people's arms, which has been a topic of public interest. In the next slide, I provide a very high-level representation of a vaccine supply chain. I know that Ms. Whicker will provide you a more detailed supply chain representation, and Ms. Vail will talk about its own implementation in the Ingham County. But this is adapted from the Conversation, an article in Conversation journal written by our colleague Bahar Ali-Akbarian, that looks at the Moderna vaccine supply chain. And what is important here is that all of the stages of this supply chain has been a point of discussion in the public domain. So we have talked about the lack of supply at the factories at some point, and in Moderna's case, that is done in Massachusetts. Then is shipped to the Texas Central Hub. And of course, that relates to the discussions about, well, we don't know how much vaccine the states are going to get. So transparency issues around the supply chain. And once you go out of the Central Hub and delivering it to the states and then to the counties, it is important that there is a handoff in terms of the management of the supply chain. And this handoff itself has been a significant challenge in the sense that there has been debates on whether this was a centrally planned or not centrally planned supply chain, at least at the time of Operation Warp Speed, which is now serving as the federal response team. Now, in order to give you a concrete understanding of the entire supply chain, we have the federal level representative, Ms. Whicker here. We're very happy to have Ms. Vail at the downstream end, at the county. And I want you to know that we worked very hard in trying to get a speaker from the Michigan State, but they were not available. So we will deal with the supply chain with the upstream end and the very downstream end. To wrap up my comments in the next slide, I'll make a few comments on the sort of the faster moving states. So if you remember, the last column of that table I showed you was the percentage of supply that is used. If you sort that table according to the in descending order in terms of the percent supply that is used, what you end up seeing is that typically the states, at least the top 3 states that do well along those lines, do not actually administer that many vaccines. So there is a negative correlation between the size of the state and the complexity of the problem and how much of the supply you end up using. But nevertheless, we have some comments from different state officials. That number one highlights the variability among states on how this is done at the state level. and that ranges from the fact that in the Dakotas, since there are very few health systems, it is much easier for that supply chain to work very close to being a centrally planned and managed supply chain where the state works hand in hand very closely with the hospital systems, and therefore they achieve the high utilization rate of the supply. And in West Virginia, they have somehow taken the step to work a little bit more independent of the federal programs and did not, opted out of the federal long-term care program, and that's and not necessarily use the federal guidance on prioritization, which was later changed to what they're using today. So at the end of the day, West Virginia also ended up using about 85% of their supply, which is actually pretty good. So from there, I switch it back to Dave and to our two panelists.
Excellent. Thank you so much, Vedat. And I really appreciate these remarks because I think it sets the stage for what I hope is going to be a really great discussion of some of the complexities and the realities of what we're dealing with regard to not only the distribution of the vaccine, but also the development activity. And so to get us started, I'd really like to invite Marion to share some of her thoughts on what's been going forward with the federal response to the pandemic. Where do we stand today with regard to development, supply, production, and distribution of the vaccine? And so Marion, let me turn it over to you.
Thanks, Dave. And Vedat, you're a great front person for a lot of my comments. And actually, I changing some of my comments a little bit based on what you provided. So Dave, if we could go to the next slide, please. So the organization formerly known as Operation Warp Speed, and that's the only time I'll use it today. Now we're the National COVID Response. It was important to understand what was our goal. It was to deliver vaccines to 300 million people for the American public, to develop the vaccines, to manufacture the vaccines, and then deliver them down to the point of use from a national response perspective. To date, we have 6 vaccines in various states. Proudly, 2 of them are already out there. They were out there in December. The Pfizer vaccine, which is an ultra cold vaccine. It has to be stored at minus 70 Celsius. And then the Moderna vaccine, which ships at minus 20 Celsius, but then can go into a refrigerator for 30 days. So 2 different vaccines right away, very first couple comments, 2 different complexities in the supply chain. The next 2 vaccines, Johnson & Johnson, Janssen is a subsidiary. We expect their vaccine to apply for emergency use sometime this month, probably within the next couple of days. And so hopefully for America, we'll see a rollout of the J&J vaccine by the end of the month. And then AstraZeneca, we look forward, anticipate maybe an end of March rollout for that vaccine. And then beyond that, in phase 3 clinical trials, you have Novavax and Sanofi. So two very strong vaccines already out there. J&J, we've already heard about the efficacy, and then 3 more coming on behind that. So a great time. So what are keys to an operation like Warp Speed? First and foremost, it had to be a whole of America approach. It had to combine the best scientists in the country, government, industry, academia. All 3 legs of that stool were critical to rolling this out. It wasn't one leading the way. It's been a true partnership, as we'll go on and talk more. A lot of the events, normal vaccines run simultaneous or sequentially because the investment risk, so we'll start to get into a little bit of school topics, the investment risk is primarily on the vaccine producer. And so they don't want to get ahead of themselves and incur extra costs. These vaccines were different because the US government took the financial risk with 5 of the 6 vaccines. Pfizer was a little bit different. Pfizer did not accept any upfront money from the United States government. We simply bought the vaccines from them. But with respect to the other 5 vaccines, US government is paying for the research and development. We're supplementing the manufacturing, and then of course the distribution. We'll talk a little bit more about the manufacturing on the next slide. Critical to this was a lot of market investigation, a lot of market surveys. So again, some more teaching points that your instructors always tell you. the analysis and the surveillance of the supply chain, is absolutely critical. It was at the beginning. It will be at the end of it. We're still doing it every day. I'm still doing market analysis, whether it's needles and syringes or bags and different equipment for manufacturing. It's a never-ending proposition. So what are the 4 key tenets we want to talk about? We needed to be able to know where vaccines are and the ancillary kits. It's probably something I should have brought up right away. In addition to buying the vaccine, so it is zero cost to the American public. Your insurance company may be billed, but a citizen will have no money out of their pocket, which was a great thing. But the other thing that we wanted to do after the PPE nightmares we had in the spring was to ensure that those critical items to administer a vaccine were provided. So when we provide vaccine, the United States government provides that complementary ancillary kit. So the needles and syringes, face masks and face shields, the vaccination shot card, and an overall needle card that talks about what size needle is good for a person, and then even alcohol wipes. So all of those things, we wanted to make sure that not only did we have a vaccine ready to distribute, but we had the ancillary kits. So when Ms. Vail gets it at the Ingham County Health Department, she'll get the vaccines as well as the associated kit. We wanted to ensure coverage beyond the normal brick and mortar. So we're using a variety of different methods to get the vaccines out there. We wanted to be able to know, to the extent we could, where the vaccines were and uptake. Now, what's a limiting factor there from a national level is each jurisdiction, each state, if you will, we deal with 64 jurisdictions, 50 states, 8 territories, 6 major cities, and then 5 federal entities. So actually a total of 69. They all have their individual information health systems. So there is also a limit to how much data the federal government can get, and rightfully so, the states should be controlling that data. And then the last thing is traceability, to be able to detect and identify what vaccine. So I got my vaccination about 10 days ago, thankfully. And so an ability to trace which one I got, when I got it, and then when I'm due for that second vaccination. So Dave, if we could go on to the next slide, please. So how did we do it? We took what was normally about a 73-month process for vaccination. Again, everything is normally done sequentially from a process, but because the government was paying for it, we could do some things sequentially. So you see at the very top, we did the vaccination trials, clinical trials, phase 3, at the same time we started manufacturing. You wouldn't normally do that because there's risk if something doesn't happen. We took that risk once it was into phase 3 clinical trials. We brought the FDA in early. Rather than waiting till the vaccine was done, we invited the FDA into the manufacturing plants to watch the process, to look at the data, to see the science that was behind it. It's been a critical process, but a great enabler of what we're doing. Manufacturing. When we started this process, there was really only one manufacturing facility. So we have built out the infrastructure. So it's not just building out the site that it's going to be, but it's the components inside, it's the consumable items, and quite often the people. For example, down in Texas, there's a shortage of quality control people. So we put Army military quality control people down at a site in Tamas, Fuji, to help supplement. So all of the things that, again, you learn in a supply chain class. So it's not just the brick and mortar, it's all of the internal things, even to include people. So we did that. We made sure that we had a joint federal response. So the Department of Defense, in partnership with Health and Human Service, we took the military logistic planners and combined them with the CDC doctors and came up with a national strategy. When you get down to the distribution, one of the greatest things we were able to do is the CDC had the foresight to, with their normal vaccine for children, have a pandemic option. And in that pandemic option, they had a bidding, and a contractor named McKesson years ago won that bid. And so it was kind of put on the shelf till needed. Guess what? In 2020, we needed it. So McKesson was awarded the central distribution contract and is now responsible for that, for all vaccines with the exception of Pfizer. And we'll talk about Pfizer on the next slide. And then distribution and facilities. Again, you see on the slide there, I've already talked about those ancillary kits and the things we have there. And then the last part, and this is where Ms. Vail comes in, getting the vaccine down to the administrative sites, enabling them to be able to receive the product and for them then to use their world-class processes and procedures to get vaccinations into arms. So if we go to the next slide, please. So how do we do it? So as I mentioned, we have the Pfizer vaccine and the Moderna vaccine out there. With the Pfizer vaccine, the US government just bought the vaccine from Pfizer. Pfizer is controlling the distribution chain. So they're taking it from Kalamazoo, so just down the road from you guys in the Kalamazoo facility. It ships out to either a FedEx site or UPS picks it up, and then it will go to their hub and then out to any of the points of administration that you've seen below. Now the Pfizer vaccine, a little bit different than the others. It stores in its own temperature controlled box that can store with dry ice up to minus 70 degrees. I'll tell you, so anybody that's a packager, study this box. I used a lot of my packaging experience from the Army to look at this process. So it is dry ice, put in a box that can store up to 5 trays of vaccine, and it can stay at minus 70 Celsius. Now, if you have at the end point, if you have an ultra cold freezer, you can take the vaccine out of the box and store it. But if you don't have that freezer, you can dispense vaccines right from that box. And so one of the neatest things of that box is right after it's delivered within 24 hours, the US government comes and refreshes the dry ice. From that point, you can use it for 5 more days, refresh the dry ice. You can do that 3 times. So you think about that portable box. If someone doesn't have an ultra cold freezer, we still have a solution to be able to dispense that critical vaccine. And then the last 5 days, it can go into a freezer or a refrigerator. So a 20-day cycle for that vaccine. Now, if you go down to the Moderna vaccine, a little bit different. It is packed and shipped in minus 20 degrees, and it goes to the point of use. Immediately, it can be put into a refrigerator, and you have 30 days to dispense it. So you could put it in a freezer if you'd like, normal, regular freezer where we store our ice cream, or you can put it in the refrigerator and have 30 days to dispense it. Same thing for both of them. We provide the ancillary kit. But the difference is McKesson. So I mentioned McKesson was awarded the central contract. So what happens is the vaccine is shipped into McKesson, regardless of what type. McKesson packages the vaccine with that ancillary kit. They also use FedEx and UPS to deliver to the last tactical mile. And then again, the same sites. And so 2 different ways it enters the system, but it hits the endpoint at the same thing. You know, before I go on, I wanted to actually hit a couple of the points that Vedat talked about. You know, when he was looking and showing everybody the vaccination curves, and he talked about a flat December. So, you know, think about all of the things that you wouldn't want to have happen for a national vaccine rollout. It rolled out in between Thanksgiving and Christmas and New Year's holidays. So you had 2 vaccines coming 1 week apart, squeezed in between 3 holidays. That doesn't make for a good situation to begin with, but vaccines were critical to get out there. 3 major snowstorms during that period of time that UPS and FedEx had to contend with. And then the most important thing, unlike an assembly line in Detroit where a car rolls off every 12 seconds and is very predictable, the production of vaccine is not predictable. If you think about making a craft beer and you know how much the ingredients you put in, but you're not really sure how much is going to come out of that barrel each time, vaccines are the same thing. And vaccines have to be developed and then manufactured and then approved by the FDA before they can get out. Now, what we've seen is nearly the last 10 days, over 1 million shots in arms. Everybody has gotten better at the process. Everybody's gotten more comfortable with the process. And so today I'll just kind of share with you where we're at. Pull up a little cheat sheet here. So as of this morning, 33,878,254 shots in arms. We have delivered out to all of the jurisdictions 57,487,650 critical vaccines. So someone might say, well, there's a big difference between that 24,000. Well, there's a couple things that factor that. It's the time to get there. It is also vaccine. You may have more vaccines in the arms, and sometimes with getting the data into the system and getting the uptake, that we see some delays there, maybe about a 72-hour delay. But I have no doubt that, Linda and Ingham County doing everything to get every drop of vaccine they have in their arms. So Dave, I'll pause there and certainly turn it over to Linda.
Excellent. Thank you so much, Marion. Very impressive the amount of effort that's gone into the planning, not only the distribution side, but again, the production and all of the associated elements with the overall supply chain. We would like to kind of give Linda a chance to talk a little bit about the local challenges, right? When UPS and FedEx distribute, what happens from there? So Linda, could you take a few minutes and talk about the local role and responsibility?
Yeah, I can actually speak a little bit to the state as well as the local responsibility, because we are a local rural state in the state of Michigan. And so the state merely passes vaccine through to us. They are not a vaccinator or a vaccine administrator themselves. First of all, I've had no supply chain management classes in my entire lifetime. And oh, by the way, the kits are missing the Band-Aids, Marion. I do, however, I used to work for the Pfizer Corporation, and so I am very familiar with the drug development process and appreciated your slides that really made it clear to me how we got going as fast as we did with some of those overlapping things which typically don't happen. So what's going on here at the local level is that we are indeed vaccinating with every single dose of vaccine that we get. I can explain to you a little bit about maybe some of these discrepancies in percents. When the vaccine first comes, remember there's just a little bit, and then more comes to the next week, which is the same amount. So we are planning to use the vaccine that arrives this week, that next week, because we don't know what day it arrives. Our first shipment arrived on Thursday. So as you can imagine, week 2 into this process, we've only got 50% of our shots in arms. So the more vaccine that gets out there, the more that lag week where we get vaccine on site, but administer it the next week generally, because we don't, I think ours arrived today, maybe yesterday. So we can't plan to use it this week. So as it first came out, that happens. As well as the first vaccine out was Pfizer, which comes in 975s. So when you have a small population that can receive Pfizer vaccine and you're getting 975 doses, because they can't break it down any further than that, that goes a lot further than in a population where there is a lot of people. So low population areas in the beginning will look like they're exceeding because they got that Pfizer vaccine at the beginning, and it comes in 975s, 1950, 2925. It doesn't break down any further than that. Moderna is 100 doses. The other thing is we see a little bit of a delay in the long-term care project where the vaccine was deployed straight to pharmacies. And those pharmacies went out and did vaccinations in our long-term care facilities. And that has been, 1, a long process, and 2, we've experienced a few glitches along the way. So that's kind of some context there. So I will tell you that locally, the state finds out how much vaccine is going to get allocated to them in a week, usually early in the week. They spend some time now with a formula that they have around population, social vulnerability index, 1B essential personnel estimates, and then they then make a decision on how much to allocate to us based on those things. So that happens during the week. And then by the time they make a decision to allocate to us, typically I find out on Friday how much vaccine I will be receiving, probably Tuesday of the next week. So that's about as much planning as we have. I wrote the plan back in 2002 in Kalamazoo. That was my first job in public health, was the emergency preparedness coordinator. At that point in time, there was a credible threat that there was going to be a smallpox release in the United States, and our federal government funding to create mass vaccination plans and fund people to do that planning said you have to vaccinate your entire population in 3 days. So we wrote plans 20 years ago now that would vaccinate our entire populations in 3 days. I wrote that plan. Now, did I ever think we would really vaccinate? In that case, I was in Kalamazoo, 250,000 people in 3 days? No. But could we vaccinate this entire population in a month? Absolutely. So the plans are there, and that's what's going on. So that's how the state and local, is going on. So they get an allocation to us. We get into our clinics that week. We use every bit of vaccine that is being used. Our challenges literally are how much are we going to receive and when, as well as some really at the level of a number of health officers, some concern about whether they truly will receive those second doses. And so that concern is out there as well. I am a health officer that continues to believe that that what I got last week is at least what I will get next week. And so I keep going and scheduling appointments out, as opposed to every week saying, okay, we got this many doses this week, everybody sign up. And then within minutes, it's all gone, and it frustrates everybody because it's like a lottery every week or every day. So I use this quote from Martin Luther King Jr., which is what I think I've been doing. Take the first step in faith. You don't have to see the whole staircase. You just take the first step. We are more than the first step up the staircase. However, we still can't see the whole staircase. So we just keep taking the steps one step at a time. So let me just go through these slides real quick, which just show you the process of a mass vaccination clinic once all of this is on site and we've gotten past all of the confusion of how much is coming on site, when's it going on site, and following guidance. I do want to point out one other thing though. West Virginia and not following guidance, we all fill out a COVID provider agreement that says we will follow the guidance. So we don't drift from guidance, and I don't know how that happened or how it's being handled, but that becomes a real struggle when people think these people over here are getting vaccinated, but we aren't here. So let's just go ahead. So this is our clinic. On site, we have incident command, emergency management from Michigan State Police, and then we also have on-site incident command and emergency management from our sheriff's department. We get to use these 2 trailers for some meetings and strategizing and computer use while we're out there. So then what happens is there's volunteers arrive and there's a morning safety briefing. So here's Michigan State Police doing a safety briefing. And then you can see that these are the people standing around during that safety briefing. We have National Guard on site with us, as well as our staff from Lansing Urgent Care, staff, sometimes volunteers from our health systems, but really just a cadre of volunteers around the community. And then when these people get done with this briefing, we break up into smaller briefings. So you can see Sarah here as a PA with Lansing Urgent Care. She's doing now a direct briefing with the vaccinators on site, who now, if they've been there before, they might already know, but everybody needs to know what's the drill for today as well. So then what happens is outside, people are starting to come in on Pavilion Road, which some of you at MSU will be familiar with. These people in vests out there are talking to each person that is driving up. They all have the same list of the schedule for that day. They find their name on the list. They ensure that they are indeed registered. We do have a process for checking ID. So after this happens, then we get to the point where, next. Oh, this is just another close-up of that. So then we're lined up going in. So this now has become 3 lanes going in so that we don't back up quite as far down Pavilion Road. So that garage door is going to open. So the next thing that happens is, of course, verification and employment, again to the next one, is these cars start driving in. So they're driving in through that garage door you saw there, and they are being directed down these lanes. This is just continued driving in, being directed down these different lanes. Then we have somebody that stands at the end of the lane that brings the cars all the way to where this cone is, and then continues to walk down the lane and get them close enough together so we can maximize the number of cars in a lane, which we hope to be at least 10. So then, this is just the same, another person directing traffic. Then we hold them all there. So this person, there's a cone in front of them, they cannot go anywhere. So they're all on hold there. They've come in at different times. They didn't all come in at the same time. So this process is going on in parallel paths on separate lanes. So then you'll see that this is just another picture of just cars and lanes. Again, the whole operation, cars and lanes. So back one. So a registration person will come down that lane. We'll make sure that your registration form is filled out. At this point in time, we'll identify whether you're getting your first dose or your second dose, and we'll put a number 1 or a number 2 on your windshield with those, markers they use for, car sales and stuff like that. And that way the provider knows when they walk up whether it's a first dose or a second dose. In addition, next slide, the vaccination teams come down. This is them pushing a cart that has all the vaccine supplies on it. And so they would go window to window down this lane of cars and administer vaccines straight into arms through the car window. We, of course, during the registration process, ask them to remove a coat or a jacket so that when the vaccination process is happening, it happens quickly. And then they continue moving down this lane and vaccinating. They write the time that the individual got vaccinated now on the windshield as well, but we go by the car that's at the end. So the last one gets a time on it. That whole lane of cars gets released at the time 15 minutes after the last car. So that means the first car waits maybe an extra 5, 10 max minimum. Nobody cares. But we don't allow people to drive after they have been vaccinated. We must monitor for 15 minutes for adverse events. That adverse event could happen at any split second. So having them drive out of here to another area to wait to be observed is probably not the best idea, but I do see that happening some places, and clinically that gives me some concerns. So they will all stay here for 15 minutes. And then we have that table right there, which is where MCR, Michigan Care Improvement Registry, is going on. So basically those MCR forms are being entered, that data is being entered on site every day as we vaccinate, rather than 1,000 papers coming back to the office and a big data entry project happening at the end of the day. So then we have basically also going on right here, this draw table. So this group of nurses at the draw table sit there with those doses of vaccine and draw dose of vaccine into syringes all day long, place them in these blue baskets. Then when the vaccinator teams need more doses of vaccine, they come and they get the blue baskets and they keep on going. The person in the far right over there in the back is my immunization supervisor, Wendy. I will tell you that once we put that vaccine in a cooler, one of the other things is we can keep it for 5 days in a refrigerator, but we can only transfer it in a cooler up to a certain number of hours, like 7 or 8 hours. So we do not even bring all the vaccine on site that we use that day first thing in the morning. We bring some on site first thing in the morning. We bring the rest on site towards the end of the day. That way we know we've had it in a cooler for a certain amount of time. We can still keep it refrigerated for that 5 days. Once it's at room temperature, we have to use it within 7 hours. So there's a very careful control of all of that going on, really by Wendy and her team at these draw tables, really about how much vaccine comes on site at any given time to make sure we don't exceed that cooler portion of it, as well as managing the amount of vaccine that's now out of the cooler and at room temperature. And especially at the end of the day, watching, it's like, okay, another car came in, oops, one more car came in, get out another vial, right? Now we've got to use the 5 or 6 doses in that vial. But that's all very, very carefully watched all through the day. So at the end of the day, we'll either end up with a few vials, very, very few, that must be used within 5 days because they're now at refrigeration temperature, or maybe a handful of doses that must be used within 7 hours. I do believe it's important to have a plan to vaccinate the correct people. I hear from some of my colleagues that it's like, it just doesn't matter. We don't have time to be, being diligent about eligibility checking. And it's like, I disagree. We do have the time. If we can do it in an operation like this that does 180 people an hour, and you receive only 400 doses of vaccine a week, and we can determine eligibility, I think you can too. So those end of the day vaccines, if they are there, our partnership with Lansing Urgent Care allows us to quickly get people who are accustomed to coming in to, you know, very short notice appointments and that sort of thing into the arms of our elderly population, and oftentimes specifically into our elderly population of color. So that really is the process. I think that might be my last slide. There we go. This is a little bit confusing. So as you can see, we received, was 975 doses, but we received it on Thursday. So we started vaccinating with it the following week. That 975 doses became 1,135 because we can't show a negative inventory. So when we get that 6th dose for vial, that inventory gets adjusted up to what we actually administered. So going down this path, you can see doses received, doses administered. And you also can note here, you know, we're starting to get these bigger numbers. These are 1st and 2nd doses now going on after the first 3 weeks. So next slide will show you where we are right now. We will, as of this week, assuming it is all on site, have received 21,795 doses of vaccine. And by the time this week is over, we will have vaccinated at least 17,267 people. That green bar at the end there was because I put this together based on partially what we'd already done this week, but also schedule for the remainder of the week. So that is where we are. Again, that discrepancy between doses received and doses administered is going to narrow as we have more doses that have been received, and we only have the fewer doses left behind to be administering the next week. So you'll see that gap close. I think that's part of the reason for it.
Fantastic. Thank you so much, Linda. I really appreciate, Linda, you and Marion taking the amount of time to really share the detail behind this process. I'm not sure that all of us really get the understanding of what is happening and how enormous this overall task is, both nationally and at the local level. I want to actually move to some questions right now, if I could. We've got some questions coming in from some folks, and you know, Linda, I'm going to direct the first one to you because I think this is something that is certainly on my mind. We're seeing more and more that vaccination doses are being distributed to retail pharmacies and supermarkets, and you know, Meyer just went live with the announcement they'll be getting vaccines too. I'm very curious, how is this being coordinated between your organization and Ingham County? I mean, your remarks about, look, it matters what order we do this in and who gets the vaccine. How are we managing all of these? I mean, this is an omni-channel challenge, right? In supply chain. How are we managing it? Do you have any insights you could offer on that?
I do. I mean, some of what's going on with the pharmacies is a little chaotic right now because they're putting out that they're getting vaccine, but we really don't anticipate some of them getting vaccine for quite a while now. And I think they're leading people to believe that any minute now they're going to have vaccine and I can just go to Meyer or Walgreens or whatever and get one. And that is not the case. McLaren here in Lansing redistributes their vaccine to a Walgreens. So their patients are getting vaccine at Walgreens. There is going to be a direct pharmacy contract with the CDC, the federal government soon, where some pharmacies in, I think it's 1 million doses around the entire country will be distributed to these identified pharmacies. Now, 1 million doses isn't going to go far, and it's going to go to particular areas where the need is there, the vulnerability is there, the populations of color, those kinds of things are there. So it's not like every single pharmacy in all communities are about to get vaccine. That is not happening. And quite honestly, right now, with vaccine being so scarce, we can deliver all the vaccine that we are getting allocated every week through our own system. And bringing a bunch of other systems in who may not be as diligent about the guidelines, nor as diligent about making sure that we must have plans that reach our hard to reach populations. Our populations of color have been disproportionately impacted by COVID illness, as well as COVID deaths. And we cannot disproportionately get to them with vaccine as well. So
Just a brief, no, I appreciate that. Just a brief follow-up on that one though. So we've got all of these channels with people signing up, maybe 10 different places. How does that impact your ability to accurately predict how you're going to be able to distribute? If you've got a patient that signed up in 4 different places,
it doesn't impact us at all, because what we do is we collect a registration form. So you register us to say we're interested in a vaccine. When we open up appointments, we send you a scheduling link. When you get a scheduling link from us, it's not lottery day. You don't have to click it fast to get one of the few appointments that came up. You got a link because there's an appointment for you. If those don't get taken up within a certain amount of time, then we send out more, and we assume those people probably went and got their vaccines somewhere else. We do have the occasional time where we have an appointment for somebody that may be a couple weeks out, and then they get a call and they get the vaccine through Walgreens as a result of being a McLaren patient. And we do hope that those people will call and cancel. But we do also have ways to manage that vaccine so that if there are a few that are not canceled, we manage to flow on through.
Great. Thank you, Linda. Marion, a question coming your way. What do you see as the biggest bottleneck or logistics issue in the distribution process? And how do you see that changing over the next several months?
So I think Linda did a great job. I'll tell you what, if I had Linda working on my team, we'd have a lot better situation, because Linda, I don't disagree with a thing you said, particularly about being able to control the environment and know who to get in and out. So you saw that I was taking notes. I was actually writing a lot of your best practices down. I hope you don't mind.
You can come for a visit if you want.
So I'm from Michigan. I'm actually a Michigander. I work for the Department of Defense in Michigan. So I'll come visit you when I get back home, without a doubt. I think the biggest challenge is just what Linda talked about. It's the vaccine predictability. It is getting a cadence and a flow. And right now, we worried about vaccine hesitancy, and you still have that. But I'll tell you, they surveyed my work back in Michigan, and 80% of the people want a vaccine. People are scared, they're tired, and they want to get back to normal life. And so the vaccine hesitancy that we saw really climb in the summer has dissipated as people missed holidays and weddings and all these things. So I think the biggest thing is ramping up the supply. Now, you heard the Biden administration announce that more vaccine would be rolling out. We're rolling out more and more. That's as the vaccine companies scale up their production as well. When we get the Janssen vaccine, that'll be more of a game changer because it's a single dose vaccine. One of the concerns is, and actually Linda kind of also brought it up, that second shot. Linda, we will guarantee that second shot will be there for you. And I'll tell you what, if something happens and you don't get it, you can call me and we'll figure out what happened.
I am a health officer that has that faith. Talk to the rest of my health officers that are trying to hold back doses because they're worried you won't give them a second. But like I said, I keep taking those steps.
And Linda, you're not wrong. I was on a call with California Friday night, and the same thing. They consciously were holding thousands of second dose because they weren't convinced. And so we actually have regional calls tomorrow, and I'm going to have General Perna, who's our chief operating officer, actually foot stomp a couple of those things. But I think those are the two biggest things is getting the messaging out there about that second dose and getting more vaccine out there. Those are the challenges. The other thing, and I thought you're kind of going to go here, is what other things? Global competition now, as other vaccines are being developed and dispersed. The need for needles and syringes is going to grow. 70% of our needles and syringes are coming from China. Now, one of the good things is that we did was we bought way up front, and so we're getting those deliveries. But I'll tell you, it's just kind of like any kind of good business model. There are some times that we're being told, oh, sorry, your weekly production got taken by something else. So you always run that risk from a foreign environment of maybe your production being delayed. And so those critical supply components are probably the biggest challenge because everybody needs them now.
So just piggyback a couple of things on that. One of the other supply chain things with all of that is that when you find that 6th dose in a vial, which by the way, Marion, we don't always get. So Pfizer's like, we're going to ship it out as if it's always there. It isn't always there.
So let me talk to that now. So I just came up with a new thing for you. So 2 weeks ago, Linda, we changed the Pfizer kit. The original kit didn't have necessarily all the low dead volume needles you would need. It's been rechanged. If you have a combination of 3 low dead volume and 3 standard, well, we put an 80-20 mix in there for you. So
Okay.
starting the 20th of January, all Pfizer vaccines roll out with what I call affectionately the Super Pfizer Mega Kit, and it'll give you enough needles and syringes to facilitate 1,170 doses.
Right.
So
That has been, we've had to order our own syringes
Right.
to fill in that gap between the 975 and whatever we end up getting out of there.
Right. So it was a nice problem that you could get some extra doses. Now that the FDA has come on and said you can with this product, we've actually facilitated you with that extra product.
Great. I will let my staff know that. That will be helpful.
Okay.
But I'd also like to speak to the vaccine hesitancy issue because it does vary. So you work in an environment, Marion, where probably, you know, it's like, oh my gosh, you've been working on this. We all got to get vaccinated. Teachers, our school districts, the uptake there, you know, 75, 80%, but in some populations not. So currently we have demand that far exceeds supply. Eventually, we will be trying to get people to take this shot so that we can get to that herd immunity. I think eventually we're going to get to a point where, hopefully not, hopefully there'll be enough experience behind this that people will cast away some of their doubts. But we do know that even our people of color, our young people don't think they need to get vaccinated because we can't get the flu, we're healthy, it's no big deal for us. We're going to find issues there. We're going to find issues with our people of color because of historic issues with our healthcare system. So there is going to be some work still on vaccine hesitancy.
No, Linda, I agree with you. And I think it's people like you that kind of share that message that that's what's got to kind of happen. You know, I have a 22-year-old daughter. Now, fortunately, because of what I do, she gets her, and she's a teacher. She just became a teacher. So she gets her vaccination Saturday and she couldn't be happier. And you're absolutely right. The teachers are clamoring, but we do have to worry about once we get through that tranche, how do we effectively communicate? And I'll tell you, I'd love to hear if you've got ideas that I can take back to the CDC from a national perspective. We'd love to hear that as well, because it's the grassroots level, such as Ingham County, that's going to help with the best business practices all over the place. So thank you.
And I actually was just appointed to the governor's Protect Michigan Commission. And that is very much the work of the Protect Michigan Commission, is education about vaccine, dealing with these different populations and vaccine hesitancy issues. So I will.
Well, I hope you take your best business practices to the governor, or I do.
This is excellent. You know, I as I'm reflecting on what I'm hearing from you and seeing the questions that are coming in, you know, a couple of things that become really obvious is just how critical communication and best practice sharing is in some of these areas. And so a very quick question to you, Linda, you know, you've developed some fantastic processes for Ingham County here. And you just referenced the governor's commission there. How is practice being shared across the state, whether it's with other county health departments, whether it's with hospitals? Is there a mechanism for doing that?
You know, it's been a bit fractured. I mean, health officers share information, best practices. The state asked us for our plan when we put together the plan around the vaccination site we have. A drive-through operation is far and above the best way to do this particular vaccine, because it naturally puts into place the social distancing and all of the things that you need without bringing people indoors into a setting where we're telling people we don't want a lot of people indoors. But a drive-through vaccine in Michigan in the winter is not the easiest thing to figure out. So we were very fortunate to find that facility. You've got southern states that can easily do drive-throughs. We look forward to spring when drive-throughs become easier. Definitely the way to go with this vaccine because of the social distancing issues there. But I forget what your question was.
It was just about communication and how we share best practices. So Very
Yeah,
helpful.
so I mean, everybody's kind of doing different things based on different facilities they have. Those plans that I told you that we wrote years ago didn't kind of anticipate social distancing. It's like we need to get people in and get them vaccinated before they get exposed to smallpox. We need to get people in and get them vaccinated before they get H1N1. We did H1N1. We had people just standing in lines and crowded in, registration line, then a vaccination line, et cetera. We can't do this with this vaccine. So lots of people are retooling and sharing some best practices, but it's kind of off to a clunky start with regard to that, because we did all have to retool our kind of processes very quickly in order to do something that could be a mass vaccination and accommodate social distancing and 15-minute wait times. And, I've seen places where, somebody shot me a picture of a hospital where they were literally cramming people into a room for that 15-minute observation period. I've seen hospital drive-through clinics where they never stop driving. They give them their shot, they keep on driving, and they just keep inching forward in a line until they then get released. At any moment, that adverse reaction could happen and that car could run into the next car or whatever. And what it does is creates a vaccine. I mean, we'd love to have a faster flow through, right? We could do faster flow through if we weren't holding everybody for 15 minutes. So if you just push people through a line so fast that you've got just a ton of cars sitting in a parking lot to be monitored for 15 minutes, that again causes me to go, wow, we're looking for a clinical nightmare to happen with not enough observation going on safely and with people continuing to move and drive in cars rather than once you have your vaccine, you are there for 15 minutes. We also do have a plan for those folks that we have to wait 30 minutes as well. If you look back at our slides, the cars are all way far over in a lane.
Yep.
So if somebody needs to wait 30 minutes when that lane gets released, they pull out around them. We get that person moved over to the other side and they wait the additional 15 minutes and another group comes in. So it does also allow us to have, we have another door where emergency response can come in. So if we were to ever need an ambulance to come in, it's got a space to drive up right beside those cars.
Fantastic. And so it's very clear, right? Planning is what allows us to be able to do these things really well. I really appreciate the additional time, Marion and Linda, that you've taken to be with us here this afternoon. I'm really grateful for the insights and the work that you've done and for sharing some of that with our audience today. I think it's very clear to me that so many of the supply chain principles that we rely upon, right? Visibility, transparency, trust, all of these things matter deeply in this process, whether it's at the front end, manufacturers working directly with the manufacturers, with the FDA, with others, whether it's on the distribution end, working with our local communities, again, to build that trust and belief that this is safe and this is something that we need to do for everyone, I think is so critical. So I do want to thank you both for being here, for taking the time today. Just incredibly grateful for the work that you're doing and for sharing it so well with our audience today. So thank you both very much. A comment for our audience out there today, just a reminder, the 5th session in our webinar series scheduled for next week on Friday, February 12th. Two of our faculty, Stan Griffiths and Sriram Narayanan, will be with us talking about general lessons learned from the COVID-19 pandemic. And in addition, as Vedat mentioned up front, we would invite you at any time to join us for any of our supply chain executive education offerings, including our value chain management certificate program being delivered online this spring, as so many of our programs are. So with that, thank you all for your participation. Thank you, Marion, Linda, Vedat. Grateful for your time today. And we hope that all of you remain safe and healthy, and hope you're able to join us again next Friday, February 12th. Take care, everyone.
Dave, can I add one thing, if you don't
Certainly.
mind? It's just that because you were running the show, you might have missed that there are tons of questions in the Q&A that we weren't able to get to.
Absolutely.
So we would at least commit to passing the questions on to the panelists or responding to some of them ourselves to the best as we can. So we're sorry for not being able to get to that, but we'll try to get you some answers if we can.
Absolutely. Thank you, Vedat.
Oh, and there's a question in here that says, just a note, we can hear music. Is the presentation maybe? My partner is a musician and they're rehearsing downstairs.
I heard that,
I
Linda.
did my
Thank you.
best.
Thank you for sharing that. Again, thank you so much, everyone. I hope you have a fantastic afternoon. Stay safe, stay healthy. We'll see you soon.
Take care, everybody.